Critical care, shortness of breath. HD. Ms. Lopez, a 38-year with significant PMH of hypothyroidism, HTN, dyslipidemia, not control, comes to the ED with shortness of breath, weakness of dyspnea and exertion, PT symptoms began 4 days ago with generalized weakness of dyspnea and exertion that has been getting worse. She have had episodes of PND and orthopnea in the past month. Dinia's chest pain. She has noted to have lower extremities edema at the afternoons. Dinia's diarrhea, nausea, fevers, or chills. Complaints about cold intolerance, weight increase, dry skin, and abundant menses in her last periods. PT reports she had a cold 2 weeks ago. Past medical history: hypertension, hyperthyroidism, treated with radioactive iodine, now hypothyroidism. The surgical history: uterine fibroma. The family history: the father decreased liver disease and the mother decreases an accident. The social history: no tobacco, drugs occasionally, alcohol, education, high school, unemployment, family and social situation, divorce, and no children. The medications: currently not taking any medication, allergies, MKDA, physical exams, the vital signs T, the temperature 36.4, HR 81, RR 18, and BP 101 to 75 beats per minute. The image: procedure, GR, chest to videos, exam date. The impression: enlarged cardiac silhouette with prominence of intestinal making suggesting pulmonary interstitial edema, bivascular opacities favored to represent bivascular atelectasis versus consolidation, blunting on the right costopharynx angle with fluid in the right horizontal tissue suggesting a small right pleura effusion. They did a echocardiogram. Interpretation summary: left brain systolic function is severely reduced. There is a severe mitral regurgitation. The right ventricular systolic function is middle reduced. The left ventricle is midly reduced. The left ventricle is midly dilated. Ejection fraction minus 55%. The EKG showed Q wave in AVL and V1 to V6. And Ms. Lopez is 38 years old with PMH, HTN, hypothyroidism, and needed for acute systolic HF. The acute systolic HF, CVAD versus HIV cardiomyopathy versus post-viral cardiomyopathy versus hypothyroidism versus connective tissue disease. The EKG Q wave is an AVL on V1 to V6. Echo showed the left ventricular systolic dysfunction, EF 55%, HIV order, VAU order to RA or toxic cardiomyopathy, despite is less likely because PT denies any drug use. Sarcoidosis is less likely since no LAD found on the physical exam. CAD will consult cardiology. Try cath tomorrow, most likely related to uncontrolled hypothyroidism since PT does not take meth. The patient not take meth. And will order any DNA test, RF, and any NA to rule out connective tissue disease.